those are a little bit advanced, but which I really learned in the past half year. So I'm picking up most important case to explain what is important. So let's start with the basic, which already Gary Mint showed. And when we look into the plaque, importance is calcified plaque. And by IVUS, you see the hyperintensity and acoustic shadow. And by OCT, you can see the thickness. That's very important. And then when we look into the lipidic plaque, you have to see the very strong attenuation. That's lipidic plaque. And then everything else, we consider this is fibrotic. And for a long time ago, when I learned of IVUS at the first time, I was taught this is soft plaque, and it is true. So this is a patient is 23 years old male, and the patient had transplant 9 years ago because patient had hypoplastic heart. And you see the very simple type A lesion in the LAD. And we did IVUS, and we see very concentric kind of soft plaque. And proximal portion was big and normal, and this is in the myocardial bridge. And many people thought this is really soft plaque. And this operator was so careful person, he never do the direct stent, but because of this soft plaque, he did the direct stent. And that's really starting the nightmare. And you see the stent was never expand, and we did a lot of balloon, nothing happened. And finally, we decided to ablate of the stent, and then using up to 2O, and then finally ablate. But even after ablation of the stent, never open up, and finally cutting balloon open this very fibrotic concentric plaque. So this is IVUS. At the very beginning, you remember this is very concentric fibrotic plaque. After stent, no change at all. You see the stent size is exactly the same compared to the first. And then after LOTA, stent has gone, and still we couldn't open, but because of the stent gone, and we could open finally by cutting balloon, at the end we have to put one more stent. So I think it's important, yes, calcium is important, but this type of the very rare, concentric, very matured fibrotic plaque is sometimes making such an issue. So those things we really have to remember, number one. Number two, this is very important case for me. I learn a lot. This is very, very long LAD region. I have no idea where to wear. And there is a bunch of the branch. But I think once you see this type of the region, actually it's very predictable, which I learned. So starting with IVUS, and I measure, I explain very carefully. So this is a very proximal LAD, medial to media is 4.9. And after the big diag, the media to media is 4.1. And after the big second diag, is media to media is 3.4. And after the big third diag, is media to media is 3.0. So now you really understand this is very predictable. It's not like I have no idea. You see the 4.9, 4.1, 3.4, 3.0. And where vessel small, getting small is where the big side branch merge. So this type of the logic is very predictable. And actually, Gary Mint, he showed this kind of concept already 30 years ago. So analyzing the bunch of the artery every 2.5 millimeter. And LAD taper is the largest compared to the sulcal and right coronary artery. It's almost 2 times. When you consider 10 millimeter in length, the vessel taper is about 0.33 in LAD, but sulcal and right coronary is half. So let's consider you have the big artery, and you have to put 30 millimeter stent. And the proximal measurement is you indicating I need a 4 stent. But when we put the 30 millimeter stent, automatically you have to imagine your distal end of the stent has to be 0.33 times 3 has to be 3. So those kind of logic is very important. We are considering the long diffuse region. That's number 2. Number 3 is this case. This is 67-year-old male and stable angina. You see the proximal LAD in distal portion, there is a diffuse disease. And we start treating, and this is a picture. And OCT, you see the circumferential calcium, but it's okay. This is very focal. So we did the balloon and we stent. And this is a whole treatment and nice ballooning and long stent and non-compliant balloon based on the sizing of each segment. So we use a different size of the balloon because we know the LED is a vessel taper. So 2.75 and 3 approximately. This is afterwards, what do you think? So long stent looks okay, but doesn't look okay in the distal portion of the stent. So you have imagination what's happening here already. And I will show the answer. This is IVAS picture. Starting the distal looks normal. Coming back, what is this? And stent. And you have idea. This is very clear answer what's happening. So would you like to stent? I will show one more time. Starting distal, and you see the nice intramural hematoma, and stent. Would you like to stent? That's a question you have to answer. We didn't. Why? And we measure the area, and this is large, and at the site of the hematoma is not large, and stent. At the same time, we have to treat other segments. So I said, let's leave it alone and go next. At the same time, we start treating the other segment. And the mid LED was underexpanded, additional balloon, and we have to treat the proximal portion. And then this is the final angio after treating the other segment. We didn't touch at all for the distal segment. It's very different compared to before. Looks like very narrowing because of the hematoma, but now we didn't touch at all, but looks much better. And we have the answer by IVAS. This IVAS, right after the stent, you see the very narrowing. This is now. And we give the nitro, that's one answer. You see the distal reference is much larger. At the site of the hematoma is also larger. And the hematoma looks smaller. And the whole answer why this happened is because of the entry site of the hematoma. This is at the time of the stent, we see the big dissection. That's medial dissection longitudinally extend, and we see the big hematoma. However, this case, remember that picture, actually the stent was covered the entry side of the hematoma. We saw that. And we confidently leave it alone because entry side was covered. But at the end, we come back to confirm that actually hematoma did not worse, and we finally leave it alone. So all hematoma, even such big, doesn't have to be treated. And the importance is checking the entry site was covered or not. And that's the answer. Then let's move to the next one. This is a very teaching case. So this patient having the already previous angio and FFR was positive in the LAD and diag, and we decided to treat LAD diag as well as a distal circ. And first we go to the circ, and this is IVAS after the treatment. Distal is normal. You see something here, and big dissection, and stent. One more time. Normal, and you see some stagnant flow, and dissection, and stentage. I was there, and I am explaining, this is okay. This is not big dissection, and lumen looks large. Leave it. I said so. But we put a wire, and then to see what's happening during the LAD treatment. But please remember this picture carefully. I did a big mistake. If you go to the distal, it's normal. This is actually bad sign of the hematoma, and the big entry site that's opening right distal to the stent. And we move to the LAD treatment, and then after LAD treatment, we see the circumflex, which actually occluded. Oh my goodness. And then operator putting the wire into the circumflex, and then I saw the wire is actually the fourth lumen. But considering the whole picture, this is a very important aspect. We see the big entry site, but we know that entry site is just distal to the stent. So that's good landmark. And the second, there is a side branch. I see the side branch in the IVAS. So if you look into the wire, into the just distal to the stent, and going to the side branch side, you should be able to take in the true lumen. And this is after the wire into the true lumen. It's a little bit difficult because of the wall is very normal, but it was into the true lumen, and we just cover at the entry site. After cover the entry site, it's fine, and then there is a hematoma, but that's no longer extended distally. And this is the final picture. This is actually unfortunate. We have to put such a long stent, but we really open the artery at the end of the procedure. So considering a two different case, what's the difference is first case was entry site was already closed, but second case was not. That should be determined what we should do. That's a fourth important point. And this is actually the one more case. And compared to the previous case, what's the difference? Yes, there is a big dissection after the ballooning, and you see the hematoma. But what's the difference compared to the last one is this is actually perforation. You see the vessel wall is no longer is present. And this is what we call the impeding perforation. And sometimes you see this type of picture. This is very, very important. And we recognize, and I expect that's going to be perf. And after stent, we see the perf, but that's a small. So once you this type of the picture, you have to be careful because you are going to be making worse, and you have to be more conservative way. But this type of the phenomena is a little bit difficult by us. We can recognize by OCT much easier. So this is a case, LED diag bifurcation. And after the cutting balloon, we see this type of the dissection. Is this dissection, it is something else? And we did OCT. Starting from the distal, you see the big dissection. This is perfectly fine. This is just treatment. But coming back more, what we see is really correlated to angiographic appearance. Coming soon, somewhere here, it's a very strange picture. And what is this? And we come to the LED. And actually, I do think this is type 1 perforation. And typical 3 layers appearance of the coronary artery is you see the low intensity, which is medial, and you see the adventitia, which is hyperintensity. But this picture is you see nothing, meaning no adventitia at all, and you see the perivascular tissue adjacent to the lumen. This is really the perforation. We can detect impending perforation by OCT very accurately. So this case, however, nothing happened. We go ahead conservatively, and finally, this is after the stent, and that segment was already starting the thrombosis. I see there is no adventitia, but you see the hyperintensity over the perivascular tissue already. So those very important findings we should learn for the complex PCI. This is a final picture. So the last one, this is my fifth important message to you. This is a patient 81 years old male. And there is a bypass in the left side and right coronary artery, which was stented about 1 or 2 years ago. And you see the very focal stenosis. And this case, when we did IVUS, we see the very typical picture. So come to the proximal, all the stent was well expanded, opening. Distal segment is well expanded, good opening. At the site of the stenosis, what's happening? There is a neointimal aplasia, but there is no stent slot here. This is really clearly partial stent fracture like this. And because of this picture, we recognize there is no stent anymore here. We have to put one more stent. So we put a megatron because we thought that was fracture, and then we see nice stent expansion at the end. However, the patient coming back later, 9 months later, we see almost same picture in the posterior right coronary artery. And then we did IVUS again, and we are so surprised. That's very different picture. So go to the proximal 2-layer, nice expansion. This time is 2-layer, nice expansion. But at the site of the stenosis, it's not like the fracture, different type of the fracture. You see, this is like the multiple layer inside of the stent. This is so-called overlap type of the stent fracture, the partial fracture overlapping chronic stage. And because of this, we thought we don't need to stent, but we just have to open the stent well, and we did. And this is after the opening by very big non-compliant balloon. Finally, we got the good lumen, and finally, the coating balloon. This is final answer. Okay, to summarize, if we are talking the very complex PCI, we have to be more advanced. We have to look for the more detail. Number one, don't say soft plaque anymore. In the coronary artery, concentric plaque is very rare. However, if it seems to be a matured fibrotic concentric plaque, pre-dilatation is recommended. Be careful. Number two, vessel taper when the side branch is present, and LAD is 2 times more tapering than non-LAD. Keep in mind, and it's very logical. Number three, hematoma is the most important complication, but check the entry side. I show the two different types of the hematoma. Their outcome is very different. Number 3, actually intravascular imaging can predict impending perforation. And actually, I do think the OCT could be better. And finally, mechanism of the stent failure dictates what is the best treatment. Thank you very much.